Hey everybody, welcome to Ladies Lunch and Learn. Happy Thursday, and we're so excited to have you all here. This week we have a wonderful guest host, Kristen Winters, joining us. So we'll just give everybody a second to get settled in the room. We'll bring up our slides. They are also loaded in the handouts, and we'll just get started with some of the fun to begin with. And so just really looking forward to catching up with you all. And it was wonderful seeing so many of you at the coalition. So topic today is putting the care back in healthcare and really focusing on the importance of in-house pharmacies. And so what movie will you be going to see this summer? And are you going to go see Barbie, Oppenheimer, Mission Impossible, old school Indiana Jones for me, or I haven't been to the theater in years? And this weekend I saw Oppenheimer. My sister-in-law convinced me to see that. And in the name of balance, we're going to see Barbie tonight with my sister-in-law and my niece. So looking forward to what you all are doing. Previous to that, my answer was I had not been to the theater in years. What about you, Kristen? What are you seeing?
I would honestly see all of those. If and when our next date night comes, it would probably be Oppenheimer. My girls are a little too young to go to this version of Barbie.
Yeah, I'm setting realistic expectations for this Barbie movie. I've heard it is definitely more of an adult focused one. So it looks like Barbie is the winner for this. Oppenheimer was good. My advice to everybody is schedule your bathroom breaks. Look it up online. Lots of people say they haven't been to the theaters in years. Prior to this last weekend, the last movie I saw in the theater was Avengers Endgames, because my son convinced me to go to that with him, which was also really good. So awesome. The next thing we're just going to do is get to know the people in the room before we formally introduce Kristen. So Rebecca, if you'll launch that poll. This is where we talk about, are you a covered entity or are you 340B friends and family? And so post 340B Coalition, we sent out a lot of invitations to the ladies who attended that conference and got a lot of questions from particularly the hospitals, given that the company that I'm with is FQHC 340B compliance, about whether or not this is FQHC only or not, but we really focus on helping all covered entities in this webinar. This is a place for women to connect and grow in the 340B program together. So we've got a good mix of all types in the room, and then also 340B friends and family. So looks like mostly FQHCs and lookalikes, but also a quarter of our attendees that have responded to the poll are hospitals, and then a good amount to our contract pharmacies, and then friends and family. And then also feel free to introduce yourself in the chat as we go through. If you've got questions, let us know there as well. And then without further ado, Kristen Winters is now the Associate Vice President of Outpatient Pharmacy at OU Health. Kristen and I met probably about a year or so ago when I got introduced to her because she has done some outstanding work in patient assistance programs, and she was helping a hospital that we were working with. And so Kristen has a very extensive pharmacy background that she's going to talk to us about. But just to give the highlights, most recently she's been working in OU Health, helping them with adding in-house pharmacy where they did not have them before, and then also bringing on specialty pharmacy services in the retail setting and achieving accreditation status. So Kristen, welcome. I will let you take it from there. Really excited to have you join us.
Thank you so much. I'm so excited to be here with you all today. I love this forum, and I love the thought of women especially sharing knowledge with each other. You know, I worked in the independent pharmacy for a world before joining a big hospital world for quite a while, and there wasn't a lot of sharing knowledge in that world, unfortunately. You know, and what a shame, because in order to really compete, you know, with the big chains of the world, they really need to share knowledge with each other, because in pharmacy, if you don't adapt to the ever-changing world, then unfortunately you die, right? And so I've really had to adapt in my career over the past more than a decade, and I wanted to start with sharing kind of job highlights, how my career's progressed and what's brought me here today. So started out pretty much immediately being promoted after pharmacy school directly to a pharmacy manager at a Walgreens at a rural community. So I really fell in love with the thought of, being that community pharmacist for your rural community. Loved learning everyone's names, loved that my technicians were born and raised in that same city and knew everyone. And it was really hard to leave that Walgreens. However, I got a chance to manage an HIV center of excellence. And so that's kind of where my specialty pharmacy journey started. And I really got to see how my daily tasks impacted my small daily tasks impacted the specialty patients in such a large way. Even if you go one step further and you introduce yourself to them by name, that's not something they were used to at a chain. You say, hey, I noticed you're on this is a brand new medication for you. I just wanted to let you know that I really did check your drug interactions and everything that I had on profile, and this is the best statin, or for example, for you. So really just going above and beyond, forcing consultations, making sure I had the specialty medications in stock, that we never had to partial fill or out of stock, extra communication with those patients, extra high touch model. I really enjoyed that. Lots of CE. Walgreens required, in order to manage a center of excellence, that you had a minimum of 20 hours of CE in that designated field. So lots of CE to help support my knowledge of that disease state at the time. So I did that for a couple of years, and then started a family, and knew when I started a family that I wanted something with a little bit better hours. I wasn't ready to slow down in my career though, and was up for a challenge. And so a company contacted me and asked if I'd be interested in opening a pharmacy from scratch inside a smaller health system. And, going to pharmacy school and becoming a PharmD, and getting to rotate through different experiences and having access to EMR, I really missed that from pharmacy school. And that's what excited me about opening a pharmacy inside a health system, was that I would have access to the EMR for those patients. And I knew the value that I could bring to those patients. This health system was an autoimmune focused health system, and primarily at the time, rheumatoid arthritis and lupus. And this health system existed for 20 years. And for 20 years, the providers there saw their patients' health conditions progress to a level that they couldn't return it to. And it was the blame of the mail order pharmacy, and that disconnect between the pharmacy and the patient, and not going above and beyond and making sure the patient, one, had their medication in hand, two, knew how to use that medication, and three, could afford that medication. So I took my job very seriously from the beginning and really wanted to create a very, very special pharmacy inside this health system to meet the expectations of the owner. It was a privately owned health system, and but also felt overwhelmed. I had worked at Walgreens pretty much my entire career, both before pharmacy school, during pharmacy school, and after. And I was stepping into a new world. And he somehow talked me into, at the same time of opening this pharmacy from scratch, going down the road of specialty accreditation at the same time. And he said, you're not going to have as much time as you do right now to really write these policies and procedures. And why not do it right from the start? And so that's what we did. And in 2018, we opened in 2016. In 2018, we became the first URAC accredited specialty pharmacy in the entire state of Oklahoma. We beat Walgreens. We beat OU Health, which I am in now. But it was really our claim to fame for quite a long time. Loved my time there. Loved, obviously we're very popular for the patients. We created that one-stop shop model inside the smaller health system, and, filled as many prescriptions as we could for the patients. But that's where it came down to why I left, is because even though we were literally one of the best rheumatoid arthritis, lupus, etc., pharmacies in the nation, we could not get access, and we were URAC accredited, we couldn't get access to all of the drugs and that our patients needed. And even more of a barrier were the insurance contracts. And unfortunately, in PBM world, they do not piecemeal out their insurance contracts, meaning you can fill our Humira for all of our patients. Unfortunately, it was, unless you can show metrics for 3 top disease states, including oncology, MS, and rheumatoid arthritis, for example, we're not going to give you a specialty pharmacy contract to fill any of our patients' medications. And it was really, really frustrating. And because URAC took so much time and so much money, we decided, and we were a privately owned institution, we decided that we wouldn't renew our accreditation there because we didn't have in our health system the infrastructure to support what PBMs needed. And at that time, I started looking elsewhere, and I knew I went to pharmacy school at OU. I had both my children at OU. So I had been a student, I'd been a patient. It seemed normal to become an employee. And when I took the opportunity because I knew that the hospital had existed for so long, but they did not own a single specialty pharmacy or retail pharmacy at all. I knew that they were trying to grow their business, trying to grow their 340B footprint and needed help. And so I joined OU Health Team in 2021 when they owned 0 pharmacies and now oversee 6 retail and specialty pharmacies that pretty much encompass most of the disease states on campus, have gained access to many different limited distribution medications while here, and also have gotten some really big specialty insurance contracts as well. The same insurance contracts that I wasn't able to achieve at Oklahoma Arthritis Center. And now, as Felicity mentioned, I've been promoted to AVP of Outpatient Pharmacy, and very excited to continue my career here at OU Health. And I currently oversee 4 directors, 1 340B, 1 retail, 1 specialty, and then 1 open position, a business operations position. So very excited about the growth that OU Health has had. We've grown the business in 2 years tenfold, and currently bring in 92% of the profit of the entire organization. So I feel like we've saved this health system, and now we've kind of turned the corner to really what's next for our program. And so that's just general. I felt it was important to lead with that, my kind of job history highlights, but I'll touch on more of what you want to hear in future slides.
Kristen, quick question. When they brought you on to OU Health, was it with the intention of adding retail pharmacies, or was that just a natural progression because of your experience?
Sure. So there was discussions already of converting existing pharmacies on campus to entity-owned pharmacies. There was also discussion of converting clinics on campus to entity-owned clinics. So I will say before I got here, there were 3 big silos, kind of. Some were owned by College of Pharmacy, some were owned by College of Medicine, and some were owned by Stevenson Cancer Center. So it was really just bringing all those together and then changing the ownership structure to where the pharmacies on campus, who used to be contract pharmacies, now became entity-owned, hospital-owned pharmacies.
Awesome.
All right.
So first poll question that we have as far as the content goes is just understanding, as far as the covered entities that we have in the room, do you have in-house pharmacies or entity-owned pharmacies of your own? No, but you wish you did and you're thinking about opening them. Yes, no, but it scares you, or yes, but you're actually thinking of adding one. So there's a little distinction. Yes, we wish we had one, and yes, we're thinking of adding, or no, but we're thinking of adding one. So looking to see where people are sitting with that. So actually, Very impressive results. Most of the people in the room have their own pharmacies. So it looks like 71% have their own pharmacy. So well done, ladies. That is phenomenal. And the numbers are shifting a little bit as we go through this, but about 16% would like to add them, and nobody's scared of them. So way to go. Really, really awesome, ladies.
Pharmacies can scare a lot of people. There's a lot of red tape, right? So I'm so glad that we have some strong-willed minds in this group, and that the thought doesn't scare you. I hope that this presentation, I designed it in mind that if you did have an in-house pharmacy already, that there should be little nuggets of information, hopefully, that you learned something else today too on what you could potentially add to your repertoire of pharmacies. All right, so today we're going to talk about how to open a pharmacy from scratch. I've done that twice. We're going to talk about the process and timeline of doing that. We're going to talk about how you process a change of ownership. I've done that 5 times. 3 different times, 5 different pharmacies. So just busy in 2 years. What are the benefits of owning your own pharmacy versus having a contract pharmacy? One of the benefits of specialty accreditation, and then a little bit about the future of this industry. So opening a pharmacy from scratch, it is so overwhelming on the amount of work that has to be done before a pharmacy is opened. Really, I'm a list maker. I feel like most pharmacists are. So it really helped me to write it down. I really like Asana or Teams, a task list that you can share with multiple team members, multiple stakeholders, and you can assign. For instance, I had our data analytics and engineers assign some tasks to ensure our TPA implementation went live the same time as the pharmacy opened. I had our 340B compliance team assigned a few tasks. I had my future pharmacy manager assign tasks, et cetera. So really it allowed me to assign tasks, but then also we would meet once a week and go over progress and then where I needed to step in and really help expedite. And we had a timeline in mind. When I got to OU Health, the clinics in the building in which we were opening one of the pharmacies we're going live in November. So we had a hard deadline. We wanted to open before the clinics opened, so that way employees could start utilizing our pharmacy a little bit ahead of when the clinics would open. But we knew we had the deadline, and so we worked backwards from that deadline to set goals for different big events that had to happen before you had to open a pharmacy. But first, you really need to decide your identity. What clinics are you supporting? What is your goal as a pharmacy? Do you want to be a sterile compounding pharmacy? If you do, are going to be your top providers? What medications do they prescribe? Do you have access to those medications? 2, do you want to be a specialty pharmacy? If so, what does that mean? From day one, unfortunately in this world, people don't give you a lot of chances, right? If they come to your pharmacy and you don't have a medication in stock, are they going to come back? Do you carry C2s whenever you first open? Does that thought scare you? Do you want to go in and fill just specialty, just generics, just brands, all of the above? So deciding those things ahead of time really helped us ensure that we had the best setup from day one. 2, are you going to lease or own your building? What does that look like? Are you going to be in close proximity to doctors' offices? I know that one analysis looked at, it takes almost 10 providers really buying into your pharmacy in order for a pharmacy today to be successful. IT considerations. I mentioned your TPA implementation if you're a 340B, right? Making sure those claims are qualifying day one. Licensing and ownership is kind of a hurry up and wait game, right? You have to hurry up and get your state board of pharmacy license and then wait until they come do their inspection. And then as soon as you get your inspection, you have to apply for the next one. So hurry up and wait game, but being very organized and ensuring that you don't miss any timing there. Making sure you have access to multiple wholesalers so that way you can have medications in stock for the patients in which you serve. How are you going to market your pharmacy? How are you going to build a P&L from day one so you can market your startup expenses versus your revenue. What are your goals in revenue? What do your teams know what goals in revenue that you have? All of the above is just really important in opening a pharmacy from scratch. And that's kind of a breakdown of the timeline on which we approached it.
Just to hit on that state piece and your state licensing, that is really important. Talk to other people in your area if you're opening one from scratch who have gone through the process, because working across the country, it's a huge variance. Some states are really, their boards of pharmacy are really great to work with, and they have some really unique ways to help pharmacies open up in a relatively expedited manner. And other states are a very long, intensive, time-consuming process. And so understanding your state's timeline is really imperative. And if you're in the state of California, engage somebody who's an expert in that process. That's my best advice to everybody on the West Coast.
Definitely. Also, whenever you choose your PSAO is kind of a GPO group for insurance contracts. They will offer support as well along the way as much as they can. They might not have obviously direct relationships with your state board of pharmacy, but along those same lines, we were able to get an exception from our state board of pharmacy and get a contingent license, even though we didn't meet all the criteria. We promised that we wouldn't open without them coming back and inspecting us. But getting that contingent license number issued allowed us to move on in the process and get future licenses. So, work with, like she just said, work with your state board of pharmacy. They are reasonable. Typically, they are very pro-independent pharmacy, pro-health system pharmacy. And so they really I felt they were really on our side and wanted to see us succeed. So this is just a snapshot of the timeline, researching the minimum criteria. Ours was really, minimum in criteria. It had to be a certain square foot, had to have hot water, and it had to be secure. So if you could meet those criteria, you could get your contingent license. And so we actually contingent licensed one room. So one immunization room was our contingent license, and then we paid for an extra inspection when the rest of the pharmacy was built and secure. But it allowed us to ensure, one, that room was going to be secure. No one was going to have a key to that. We weren't going to keep drugs in it yet. But just thinking outside the box throughout the process was beneficial. What's your DBA name? Who's going to own you? And filing your DBA name with the state was also important from day one. Making sure you had liability insurance and all the different license numbers that you needed to fill prescriptions, both non-controlled and controlled. Picking a software, I would encourage you to demo multiple softwares. Talk with your independent pharmacy friends and then in your area, talk to other health systems and find out what is the best fit for you. We just switched softwares to Epic and as a whole system, and we switched to Willow. So I have a lot of thoughts on Willow compared to other independent. I could probably give a whole presentation on that alone. But we did a big bang, and so we've recently switched softwares, including having 2 specialty pharmacies at the time. And then ensuring that you have those direct contracts with PBM, so that way day one, you can fill prescriptions for Medicaid, Medicare, and commercial patients. So change of ownership does look a little bit different. There's a pharmacy that already exists and they're already doing business. So how do you continue that business while you're getting all of those things that you need on those previous slides under your own ownership? So in this case, we did obviously lean on our legal team to write up multiple, is a 77-page agreement, included multiple powers of attorney, bill of sale. We also hired a consultant. I can talk to whoever personally offline about the consultant we used, but that was the consultant is a part of one of our current vendors. So explore what I can say is ask your current vendors that you have if they have a branch of their company that offers a consultant for this type of work. They were instrumental in helping our legal team draft up some of these documents even and help support me along the way of really leading these integrations. Are the employees going to transfer? Or are you going to lease the employees? Are the license numbers going to transfer or are they not? So these are there are business decisions. It's not a cookie cutter way of changing ownership. Two of our pharmacies already did have specialty pharmacy accreditation. Is it even allowed to transfer that accreditation? And if it is, how many days do you have to process that? We had 30 days after the change of ownership. We had to process a change of ownership, and that for both URAC and ACHC, and it was very, very difficult to meet that timeline. But the powers of attorney do expire. So knowing that you have a deadline in which you have to have all of your license numbers and you have to have all of your direct PBM contracts before that POA expires, you can extend it. In addition, one question I get is, because pharmacy billing is in real time, there will be a time period in which one of the companies, whether previous or future, if you do have this business POA, receives funds that belong to the other person. I would highly, highly recommend either hiring a company or hiring a person to oversee that work. We did neither, and it was a lot of work on me, on some of my team members, to really discern. You have to discern on a prescription basis. There might be on one specialty prescription 5 different forms of payment on that one specialty prescription. And so if 2 of those belong to you and the other 3 belong to the owner, how are you going to, 1, get access to see that, and 2, do that work whenever your pharmacies might be selling over 600 prescriptions a day? But that is essential, as I will say, tens of millions of dollars exchanged hands after the change of ownership. So if you don't devote time to do that, you will lose out on revenue that belongs to you because of the delay in changing over those insurance contracts and direct deposits to your new bank account.
Yeah, one piece that we see in this type of change of ownership is the value of those current license numbers, and the legacy of an existing pharmacy, because a lot of the PBM contracts, when it is when it's a new pharmacy that's created, sometimes the PBMs will say to you, your pharmacy has to be in existence for X amount of time before we're willing to work with you. And so being able to carry over the history of the previous pharmacy can be really helpful in in maintaining those contracts. Yep. Is one thing. And then the other piece on this change of ownership is, if it was a contract pharmacy for you previously, and you might hit on this later in the slides, Kristen, if it was a contract pharmacy previously and it becomes an entity-owned pharmacy, then the changes to your OPACE registrations as well. So moving it from a contract pharmacy registration to a ship-to address on
That's
your
very
OPACE
true. That was
database.
one of the Asana tasks that we had designated to make sure that happened. One, it unlocks access to medications immediately when you have that designation change. So that was huge for us. We have a whole list of medications that we have access to because we are shipped to and affiliated with this hospital that contract pharmacies don't have. We can leverage that. 2, I had a thought earlier and it'll come back to me. I will say open communication. So I have on there communication to the state board, DEA, et cetera. You are at risk if you don't have communication that previous licensure will be closed automatically when you get your new licensure. You cannot let that happen. So you have to be very clear and continually communicate with all 3 of those entities in a routine manner during the extension of that POA to ensure and attach the business and the DEA POA to those communications and say, please leave both of these sets of license numbers in existence until the end of this POA or until we get all of our direct PBM contracts. I will say, even though we had exemplary communication, that we were shut off a few times and had to be politely asked to return on those license numbers. In addition, you do not want to flag your previous direct PBM contracts that there has been a change of ownership. So many of those PBMs that you have contracted with have their own specialty pharmacies or their own pharmacies, and they will look for any reason to discontinue their contract with you. So making sure your team knows, everyone on your team from cashiers to pharmacy manager knows that they do not tell one of the big PBMs that there's been a change of ownership. We had all the documentation to support, and we actually had some reaccreditation events come up during the POA timeframe that we had to navigate. But that was also crucial in ensuring that we could continue our business continuity during that time. So why is it important to own your own pharmacy? One is really just getting everyone on the same team. If all the employees, all the providers, all the clinics, and all the pharmacies are owned by one institution, then you have one, more accountability, right? More accountability to each other, more accountability to your patients, more accountability in, if I want this machine that costs $10 million, what do I need to do to help get that? And if you can show data that you are supporting your in-house pharmacy as a provider, then there's leverage there. Before we got here, obviously 100% of our prescriptions were going to a non-owned pharmacy. And so one is gaining access to that data so we can track over time on how much we're capturing in-house. And I will say in 2 years, we were able to capture 50% of the overall opportunity. And you can show how 1% can even move the needle. So we were able to do in 2 years, I feel like what Vanderbilt and other organizations took 10 to do. So very, very, it's accomplishable. But it wasn't easy, but really getting everyone on board and really meeting with those clinics, meeting with the providers and figuring out what they want out of a pharmacy, figuring out what barriers exist to prevent them from sending prescriptions, letting them know about the change of ownership. Say, hey, I know you might have had some bad experiences in the past with some of these pharmacies, but things are changing. We've revamped our services. We've revamped our staff. We've hired new pharmacy managers, so being transparent in that communication really went a long way. And then what else we did in tandem was we gave direct resources to our providers in our top clinics. So for example, our neurology clinic, we gave them a assistant, we gave them a technician that live in their clinic with their providers and their nurses and their patients, support complex needs, support prior authorizations, support patient assistance, et cetera. So we weren't just saying, send us your prescriptions, we'll take care of it. We're saying we're going to help you on a day-to-day basis. And the 340B program is what's going to pay for that.
Awesome.
So that ties into this, retail, there's a white paper out recently that proves that retail pharmacies affiliated with a health system not only save patients money on their out-of-pocket costs, but save insurance plans money. We have access to EMR, so we can see when medications are discontinued. We can see a patient's full profile of medications. You have more insight into what is truly going on with that patient. You can sync medications up with that patient's appointment, which will help you with shipping cost. You can increase your basket size to see what medications the patient's on and saying, hey, I'm noticing you're on this, this, and this based on your EMR. Where do you fill those at? I'd be more than happy to transfer those in and sync them up with your existing medication. You can utilize EMR to increase your business that way. Everything, I feel like everything I do ties down to two things. And one is improving patient experience, right? Whether that's outcomes, whether that's affordability of medications, but it's also how can we support this health system in improving revenues bringing in? And one of that is already I mentioned, improving the collaborations between clinics and pharmacy. That was in my wheelhouse. I did that at Oklahoma Arthritis Center. I met routinely with the doctors there. I, found out what barriers existed and we broke through all those barriers. I'll share a story really quick. In that one of the clinics I first met with here at OU Health was reproductive medicine. And they were sending 100% of their prescriptions out of state to one pharmacy. And I asked them why. And they said, well, there's no pharmacy in the state of Oklahoma that has access to the medications my patients need. And even if they did, they could not beat the prices that this out-of-state pharmacy has. And I'm very competitive, and that took quite a bit of research to figure out how we were going to overcome both of those barriers. But that's really how our patient assistance program here launched. And now we fill 99% of those patients in-house, and we save the patients a significant amount on their out-of-pocket expenses. Again, we've embedded a pharmacist and a technician into that clinic that support and fight with the insurance plans, but we have a cash plan built out for those patients who can't afford their medication as a backup when their insurance fails them.
That's phenomenal. Kristen, we got one question in the chat from Amanda, and she wanted to know if you are able to share that white paper that you referenced.
Sure. Yeah.
If you are able to get that to Rebecca after your presentation is done, before we're finished here, she can even upload it into the handouts so people can grab that.
Yeah, sounds good. And then I will say, health systems in general do a fantastic job. We wouldn't be a dish if we didn't take care of so many insured or uninsured patients. We already provide $100 million right of charity care per year. But before these pharmacies existed, what happened? Patients would leave their appointment or leave being an inpatient, and they couldn't afford their medications, and there wasn't resources to help them. There wasn't that skin in the game to help prevent that readmission. So that was key, is getting everyone on the same page, because we know that if we have to help a patient afford their medication on the outpatient side, that it could be saving our organization, $100,000 on potential readmission. So it's hard to put a value on that. However, there's just so many success stories that we can share. We've helped get patients out of the hospital. We've helped patients, obviously, who have been discharged afford their medication. And one thing that I felt very strongly about in our patient assistance program is that it wasn't just limited to OU Health patients. There would be branches of the program that could help any patient, whether they were OU Health patient or not. And
so, quick poll question, just identifying everybody in the room. For those of you who said that you did have pharmacies, of the pharmacies that are here, if you have a specialty pharmacy, do you have an accreditation status, working towards accreditation, or no specialty pharmacy? And so looks like most of those who have pharmacies are one or more. And so it's about 25-ish%. And then 67% said they don't have specialty pharmacies, and 7% said that they're working towards it. So well done, ladies.
Right. So what does accreditation get you? One is it increases access to medications. There are some manufacturers out there who say, unless you can show proof of URAC or ACHC, you can't get access to our medication. Two, I so wish that this existed when I was at my last health system, but now there are more than one specialty PSAOs out there that you can join, but they have a minimum criteria of at least one specialty accreditation. PSAO is so valuable in that they negotiate contracts with PBMs on your behalf. You're a very small fish in a big pond, and PBM contracts are very much take it or leave it. So having a PSAO doing that dirty work for you is really valuable. I will say we went live with our specialty PSAO in January, and it has been a phenomenal return on investment and phenomenal for our patients. We have so many patients who want to fill with us that we hate telling them that they can't. Two is it improves your pharmacy services. Specialty accreditation, it forces you to be a better pharmacy. And so part of that is, even if you don't get access to specialty medications or insurance contracts, it truly will force you to be one of the best pharmacies out there based on all the minimum criteria you have to meet in order to hold that accreditation. And then it allows you on the PBMs that aren't a part of the PSAO, specialty PSAO contracts, it allows your foot in the door to at least apply for those specialty PBM contracts. If you don't have the accreditation, they won't even let you apply.
And then Kristen, your specialty PSAO, is that through your wholesaler or is that an independent company, your specialty
So
one?
we chose Accelerate. Typically, you have to be a part of the regular or retail PSAO as well. And so we were already a part of Elevate. They do have an affiliation with Amerisource. So it is affiliated.
Excellent.
And then lastly, what's the future of specialty pharmacy? We have successfully gained access to 22 LDDs in the past 12 months. And, in order to do that, we have to have direct contracts with manufacturers. And we still have 340B pricing, but I think that's the future is so many more of these specialty high cost drugs that come out aren't going to be available through your typical wholesaler, and you will have to purchase direct. When you purchase direct, be ready for what they want in return. And that's potentially shared data, shared dispenses, et cetera. I love the fact that there's not just one specialty PSO out there anymore. So we need more to pop up. So there's competition and to help get those fees reduced to be included in that network. Why we're here today, increase in hospital-owned pharmacies. There's going to be more and more shift as there's been 340B manufacturer restrictions implemented on contract pharmacies. Hopefully we all pray those go away. But if they don't, we have to be ready with our own hospital-owned pharmacies in order to fill those prescriptions and to get 340B qualifications on those prescriptions. We do ESP data share. So I think more and more organizations, if they haven't, have considered doing that as well. Comparing your TPAs or potentially building one yourself it is an option as well. Another is collaborative care model. Where can we embed pharmacy personnel to really improve patient experience? We've done it on the clinic side. We've also done it on the inpatient side. The 340B program has allowed us to hire direct patient care pharmacists that literally work at the bedside of patients in the hospital. So they med administer, they help prevent med errors, dosage errors, etc. It gives me chills because they decrease the nurse to patient ratio, which has helped with contract labor. And it's just really added an avenue to our career path on where pharmacists can work and how you can serve patients. And then lastly, what I presented on earlier this week is the 340B Good Stewardship. There's a lot of scrutiny on the 340B program in general right now, asking for transparency in where we're utilizing those funds that we're getting through the program. So if you don't have an established 340B Good Stewardship program, or you don't have an internal patient assistance program to where you are passing along some of those savings to your patients, really it's reasonable, right? If we're getting discounts on medications, that we're providing some similar discounts to our patients, but going about it in a standardized way, getting legal and regulatory approval along that way, and protecting yourself in a PBM audit is key there as well. And that's it.
Yay. Thank you, Kristen. That was amazing. And even though Kristen is from the hospital world, this content does apply to all of the covered entity types that are out there. As far as the grantees, there are some who are in the specialty space. It's a big lift, so we don't see that quite as much, but we're definitely seeing the FQHCs and the other grantees looking at getting into the retail space. Things that we're hearing a lot about is independent pharmacies approaching covered entities about how can they work together. And so lots of questions about acquiring pharmacies as the entity-owned pharmacies. So this is a really important topic, especially as Kristen said, your access to 340B purchasing through an entity-owned pharmacy is significantly more open than what we're seeing with all the manufacturer restrictions at the contract pharmacies. So if there's any questions, ladies, please feel free to put them in the chat. I know we've got the one that was asking about the potential to share the white paper. And then while we're waiting for questions to come in, I'm going to jump into to the other content. And then Kristen, if we have questions that come in through the chat, I'll pop back right over to you. And so we're just changing gears we're going to put in a few different elements in the handout section that will go along with the content that we're going to talk about. So that's being loaded right now. And so just talking about since we met last, everything has stayed the same. Just kidding. Everything continues to evolve, and things just continue to heat up. So AstraZeneca has updated their policy. I sillily thought that we were going to see AstraZeneca consistently stay with their 1 year. Every year they change their policy. So 2020, we saw something, 2021, 22, or I guess 2021, 22, and then the start of this year, they changed their policy, and then now in the middle of the year. So now they only gave us 6 months since their last policy change, but here we are. So they are moving to 340B ESP. They, instead of handling their designation process independently outside of ESP. So it's nice because it's streamlined with the other manufacturers. It's not necessarily a change from what they were doing before, except for now it's being handled through ESP and not directly through AstraZeneca. The other update is Astellas is the 24th manufacturer to impose restrictions. That comes into effect September 1st for Xtandi, which is a prostate cancer medication. Randy, I'm seeing a question about assistance through your pharmacy for patients that are not 340 eligible. Did you say something, patients?
Yes. So, for example, we have a charitable pharmacy on our campus, and that charitable pharmacy is our only pharmacy that is not 340B. They're our only standing pharmacy that's still GPO, but they are split down the middle and duly licensed with the State Board of Pharmacy, overseen by one pharmacy manager. Half their inventory is retail, the other half is charitable, and you do not have to be an OU Health patient to take advantage of that inventory. And it helps us extend our 340B good stewardship because they have a GLP-1, for example, in stock almost always, plus many, many generics. So yes, not all of our programs are limited to 340B. However, we do have several 340B contingent programs.
And then Amanda, I saw you had a question, but then it looks like it disappeared, but your question was asking about being able to designate your in-house pharmacy on 340B ESP. You really should not ever have to designate your in-house pharmacy because if it's owned by your covered entity, you shouldn't have to designate it. The only thing you should be designating is your contract pharmacies. If for some reason you ever have to designate your in-house pharmacy, you would want to check with your wholesaler to make sure that they're not that the contract for that pharmacy isn't inadvertently set up as a contract pharmacy and not an entity-owned pharmacy. So that's what I would suggest looking into for that one. But you really should not have to designate an entity-owned in-house pharmacy on ESP. That should all be handled by how your wholesaler contracts are set up and how they're designated on OPACE as a shipping address. And then if I already designated my pharmacy through the manufacturer, do I have to do it through ESP? And so Dolly, if your question is about AstraZeneca, yes, because their change in policy has been announced, and they've asked everybody who designated directly through them to also go to ESP and do their designations there. So that is important. And let's see. I'm going to.
Yes, we did get pushback as well about flipping. But really, I will say getting the key providers buy-in to the program ahead of time really helped with that. I've learned a lot as being tangentially attached to those conversions. I will say to consider, if you can, flipping part of a clinic rather than the whole clinic on, especially if that clinic has a lot of in-office administration or in-office procedures, because they might have the clinic billing space is so different than hospital billing, and being able to still service their patients through both avenues it would be key. So yes, I would say one, getting buy-in, but two, considering what they're doing billing wise that could be impacted and how that could be impacted, and getting your rev cycle team involved as well.
And then Megan has one where it's not necessarily so much of a question, but more of an experience, where she's talking about her contract pharmacy through ESP. They identified it as a central fill, which was prohibited by AstraZeneca, and they're working on getting it reclassified because it's not actually a central fill, so that they would be able to designate it. So we'll jump to the next slide. Just a reminder about the recent requests for information. So there was the drug shortages one that closed on July 7th. So that came from the Energy and Commerce Committee. And then closing tomorrow is the 6 questions that came from the Gang of 6. And really looking at, this was more of a friendly 340B inquiry, asking for insights on how HRSA may provide oversight for the 340B program, questions about contract pharmacy, how we can provide benefits to the 340B program to the patients, and duplicate discount prevention, and accountability and transparency. There have been a number of the different advocacy groups and national associations who have put out letters that you can sign on to. Rhiannon, I don't know if you want to jump up. I can promote you if I can find you quickly. I don't know if you want to jump up and join us and say anything. I see you in the chat saying, please respond. I'm scrolling quickly.
I can add while you're adding her. We've already written ours, but just one other thing on the person getting pushback. We did as well. And now, especially that we don't have the immediate eligibility exception that we used to during COVID, is that one of my first projects when I got here was I created a medication therapy management clinic that was pharmacy ran and an existing licensed space. And so that clinic is open for referrals from other OU Health physicians who do not work in licensed space. And we, see patients, the pharmacists see patients, they document encounters in our EMR. Those encounters are 340B eligible, and then they represcribe those medications after the encounter. So just a little workaround that you could consider if you're having those same pushbacks.
Awesome. And welcome, Rhiannon. Thanks for jumping up with us. If you want to talk a little bit about some of the efforts that are available for people to sign on responses for RFIs, that would be amazing.
Yeah, so thanks, guys. Hopefully my camera holds out here. I just wanted to encourage you all to, if there is an association that you are a part of that is doing an RFI response, please go ahead and sign on to those. Because they're super important, and staffers have asked specifically that they have more sign-ons rather than everybody writing their own RFI. With that being said, if you don't find one that you're comfortable signing on, please do write yourselves. And the deadline is tomorrow. However, if you need any help with any of this, please let us know at CV340B. CV is going to be responding within the boundaries of our 501c3. So if you need anything, please let us know. I'll put my email in the chat.
Awesome. Thank you. And then Kristen, there's a specific request for you in the chat about somebody reaching out to you offline. So I'll let you take a peek at that. Lisa's mentioned that NAC has a draft as well. I know 340B Health has one too. So make sure you check out the ones that your advocacy groups have. Speaking of drug shortages, just be very aware there was a tornado in North Carolina that took out a Pfizer plant. and it was one that was responsible for a lot of their sterile products. And so anticipate future drug shortages around sterile products. We're constantly struggling with that, but just putting this on everybody's radar because that has happened very recently. And then positive news, CMS repayments. Yes, they have come out with a proposed rule of how they will repay everybody that they underpaid for the last few years. One of the handouts that is in the handout section, there is one that's labeled as AA, will give you a spreadsheet that if you are a hospital that was subject to these payment cuts, you can actually log in and take a peek at what your proposed repayment would be. Very fun and interesting. And so it'll say what they are suggesting that they're going to repay you. The one that is labeled with the BBB, that is the 300 hospitals that are not going to be subject to the payment reductions over the next, I believe, 16 years. That is to create the budget neutrality because they were not in existence in the time of the the previous payment reductions. So they won't get the future payment cuts. So fun, interesting information, especially if you are somebody who's expecting some refunds, but also just if you're curious. So that information is in there. We've also got an update on the contract pharmacy restrictions. We've moved beyond one page. It's a couple pages now. So that's there to download as well with the slide deck. This one's super brief, but pending court cases that we have coming. We have the 2 contract pharmacy lawsuits that are pending, and shout out to Powers who called me right before we jumped into this because I was having trouble pulling which those were. So the DC court cases are Novartis and United Therapeutics, and then the Pennsylvania 7th Circuit is Eli Lilly. So we're still pending those, and they could come back at any point now. Those ones, just as a reminder, are the contract pharmacy dispute. We've already had the 3rd Circuit come back with their ruling. We're still waiting to see how these come back. If there's split decisions, that's more likely that they would go to the Supreme Court. Genesis, that is the health center that is in legal disputes with HRSA, particularly over patient definition. The health center put filings in earlier this summer, and we expect filings from HRSA in response any day now. So more to come on that. And then the Inflation Reduction Act, which we're all getting ready for as far as the modifier components, which will start for all covered entities for 340B clinic administered and outpatient administered drugs starting January 2024. The manufacturers are suing over the forced negotiation of drug prices. So at this point, Johnson & Johnson, through their Janssen arm, Astellas, Merck, and Bristol Myers Squibb have all filed lawsuits. They have chosen to take the path of get to the Supreme Court as quick as possible, and they have made their arguments as violations of the First and Fifth Amendment, and that is their pathway to getting to the Supreme Court, essentially saying this is almost a taking of property and a violation of their constitutional rights. So more to come on that. Things are very, very exciting in the legal area of 340B. And one of the other exciting things is we have lots planned for Ladies Lunch and Learn coming up. So we've got Cardinal and the ladies from Cardinal, Vicki and Rachel, will be joining us to talk Drug Supply Chain and Security Act. And so lots of discussion about GLNs. We're getting lots of questions about what we should be doing there. So really helping everybody understand what's coming and what do we need to do to be prepared. September, we're going to be talking about using decision support order sets in primary care and how that can help improve care. we see those types of things in the hospitals, but how can we move them into the outpatient setting? Jennifer Cinconetti is actually in a FQHC lookalike. So really unique application that we don't typically see in a non-hospital setting. And so really looking forward to sharing that. And then Rhiannon, who you all got to see again today, she'll be joining us in October talking advocacy and all things 340B. So really appreciate, Kristen, you spending time with us today. We've got 1 minute left, and Chelsea also was adding in who the court cases are in there. Thank you all, ladies, for joining us. Kristen, phenomenal job.
Thank you so much.
And congratulations on your new position.
Thank you. It was a pleasure getting to speak to you all today. And yes, if you have any specific questions, please reach out to me. I'll do what I can on answering in a timely manner. So love to connect with you guys any either in person at future conferences or through this forum.
Awesome. All right, ladies, have a wonderful rest of your week.
Thanks, you too.
We will see you next time.
All right, bye.
Bye-bye.
We did it. I was getting nervous.